could attend and, you know, attend their behavioral health appointments and things like that. So yeah.
So Jenna was at CDC during that time, and she had responsibility for some of those grants. Yes.
Oh, wonderful. Yep. Well, wonderful. What a small world. I was, as you can tell, I was super excited to talk with you today and hear your talk.
It's so good. I'm so glad we're kind of getting back out and getting to move forward some of these things now.
Yes. Yes. What a time in this world, I tell you.
I agree.
Yeah. Yeah. Well, we'll get started probably a couple minutes after 2, as folks join.
Hi, Dr. Fink. How you doing?
Good. How are you doing, Lenore?
I'm good.
Good. Looking forward to the weekend. Hopefully our weather won't be so gray and overcast this weekend.
We can cross our fingers and see what we get.
Yeah. Let's see.
Let's see if I can enter this code and see if it works.
Good. Well, I think I'll go ahead and get started and introduce today's speaker. We are very honored to have Captain Karen Herod here. She's has a master's in social work and is a licensed clinical social worker. She is the director of the SAMHSA Office of Tribal Affairs and Policy. And Captain Herod is a citizen of the Choctaw Nation of Oklahoma and directs SAMHSA's Office of Tribal Affairs and Policy. Her office acts as SAMHSA's primary point of contact for tribal governments, tribal organizations, federal departments, agencies, and other governments and organizations on behavioral health issues facing American Indians and Alaska Natives. Captain Herod also serves as the SAMHSA Regional Administrator for the HHS Region 6, which encompasses Arkansas, Louisiana, New Mexico, Oklahoma, and Texas. And I had the privilege of presenting to her back in 2008 on the opioid epidemic in New Mexico at the time. And she, as regional administrator, she's working to advance the agency's mission and improve the delivery of behavioral health services within the region. Prior to joining SAMHSA, Captain Herod was a behavioral health consultant for the Indian Health Services in the Oklahoma City area, which encompassed Oklahoma, Texas, and Kansas. She also chaired the IHS National Zero Suicide Advisory Committee and served as a member of the National Suicide Crisis Policy Committee, working to establish the IHS National Suicide Care Policy. Earlier in her career, Captain Herod served as the Behavioral Health Director for the Choctaw Nation of Oklahoma expanding services related to suicide prevention, forensic sexual assault care, domestic violence advocacy, and substance use education, prevention, and treatment. Captain Herod led the establishment of the Windhorse Family Counseling Center, bringing family-centered substance use treatment to areas that had previously had little access to care. Captain Herod holds a Master of Social Work from the University of Oklahoma and is a licensed clinical social worker, as I mentioned. She is commissioned into the United States Public Health Service in 2006 and has deployed multiple times in support of both natural and man-made disasters. And we are completely privileged to have such an esteemed speaker with us today. And I'd like to turn it over to Captain Herod. Thank you.
Oh, thank you so much. And I'm honored for the opportunity to come and talk with you today. I wanted to just share briefly before I begin my presentation why I do this work and why I think that it's so important. So earlier in my career, I was honored by the Choctaw Nation to be able to stand up a family-centered treatment center. And they gave me the honor of being able to name this center. And I decided to name the center Windhorse because there's a Choctaw story about a pony that comes along people that are not able to travel on their own and allows them to ride until they are healed and able to, go on their journey again. And that's really what we wanted to do with that center. And it was an Administration of Children and Families grant, a regional partnerships grant. And with those dollars, we were able to provide true wraparound services. The aim of the program was for children to not have to go into the child welfare system, right? To stay with their families and families to be able to get healing. So I'll fast forward several years and just getting gas in a little community that was close to McAllister. And out of the corner of my eyes, I saw this really large young man coming at me yelling, "Windhorse lady, Windhorse lady." And I was a little bit taken aback, but then in that young man's face and his smile, I saw the face of a little boy that I had known there at Windhorse. And he had shared with me that his family had continued on their recovery journey, that all of his brothers and sisters were doing well, some in college. He was actually the assistant manager at that little store. And when you come alongside people in their recovery process and stand beside them, you're not just impacting that person, you're impacting their family, you're impacting their community, and you're impacting generations. And so that's really kind of the reason that I am so passionate about this work, because it changes lives. So I just wanted to share that so that you could see just a little of my heart and why I do this work, and why I am so thankful that you all are doing this work as well. So with that, I just want to share a little bit first about what my office does, the Office of Tribal Affairs and Policy. Go ahead and go to the next slide, please. So in the beginning of this presentation, I wanted to provide an overview first of what I'm going to be talking about. So we're going to talk a little bit about current trends in the overdose and substance use disorder crisis. And I'm going to talk a little bit about tribes too, but I want to talk more broadly about SAMHSA's work. But, we just can't ignore that, we're coming off of the COVID pandemic, and communities, have been severely impacted. And then many communities are on a journey beside that related, to just a great number of overdoses and facing, the opioid crisis in their community as well. But I want to share with you some of SAMHSA's activities related to this harm reduction. I've got some exciting news to share about that, evidence-based treatment expansion, recovery-oriented systems of care, and we're also going to review some policy priorities and how we hope that they're going to impact outcomes. Go ahead and go to the next slide, please. Thank you. So at SAMHSA, really behavioral health is our job. So our mission is to reduce the impact of substance use and mental illness on our communities. We do this in a variety of ways, but standing kind of essential to it is that behavioral health is essential to health. I always say that when there is a recognition, and maybe we can just start saying health, that I can retire, right? And so I want to retire one day, so I'm hopeful that that's going to happen. But we also believe that prevention works, that intervention is critical, that treatment is effective, and that people can and do recover. And it's been my honor to see people recover, and it's just a amazing journey when you can be a part of that. Go ahead and go to the next slide, please. So within our SAMHSA priorities, we have 5 priorities, and then we also operate around some cross-cutting principles. And I wanted to share a picture of my boss, Dr. Delphin Rittman. She's the Assistant Secretary for Mental Health and Substance Use. So our priorities include preventing overdose, enhancing access to suicide prevention and crisis care, promoting children and youth behavioral health, integrating primary and behavioral health care, and using performance measures, data, and evaluation. With the cross-cutting principles, equity, workforce, financing, and recovery. And we've been doing a lot of work around workforce for my office, because we've seen just a huge barrier in tribal behavioral healthcare recruiting workforce, and it's really been exacerbated by COVID. And so we've been doing some work around that in my office. Go ahead and go to the next slide, please. So my office, the Office of Tribal Affairs, if we can go back one slide. Thank you. So really serves as the primary contact within SAMHSA for tribes, tribal organizations, and other partners on behavioral health. So the mission of our office is to prioritize American Indian and Alaska Native health and reduce the impact of substance use and mental illness within this community. We lead the Tribal Technical Advisory Committee, which is comprised of leadership from the 12 Indian Health Service areas and 2 at-large positions that really inform SAMHSA's policy programs funding around American Indian, Alaska Native communities and tribal nations. We also lead the Indian alcohol and substance abuse efforts around the Tribal Law and Order Act, and all consultation, outreach, education, and engagement efforts. And I wanted to share the link there to the tribal site, so you can use this link. We have a new communications outreach. And so if you go on the tribal site, you'll see where you can sign up to get all of the information about the tribal activities that are happening at SAMHSA. Go ahead and go to the next slide, please. I also wanted to put a plug in for the regional administrators. So I used to serve in this role for SAMHSA, and so we have regional administrators that office in the 10 Department of Health and Human Services regions. So for Oklahoma, Christy Brooks is the regional, and I guess I should update this slide, because just recently the regional administrators changed their titles to regional directors. So I have to start remembering that. But Christy Brooks serves Oklahoma, and she is also a citizen of the Choctaw Nation. So you would reach out to her for any kind of regional needs that you might need apart from, she also serves tribal. We work very closely with her on tribal issues as well. Go ahead and go to the next slide, please. So I know this slide is not big news to anyone, right? In 2019, we saw a slight dip in overdose deaths, and since that time, we've seen significant increases. This slide reflects all psychostimulant involved overdose deaths. then breaks it down with opioids and without opioids. So this is a fight that we are not winning at this time. And so a lot of our work at SAMHSA is focused around this at this time. Go ahead and go to the next slide, please. So this slide breaks down overdose deaths by gender, by age group, and by race and ethnicity. And unfortunately, non-Hispanic American and Alaskan Natives have seen a significant increase in opioid overdose deaths. If we look by female and male by gender, we also see increases in both, with the 35 to 44 age group as seeing the most overdoses. Go ahead and go to the next slide, please. So co-occurring disorders are highly prevalent and can be found at really any stage of life. Their treatment requires coordinated care as well as flexibility in the provision of treatment options. So we have specific SAMHSA grants that I will discuss in the following slides, and also try to provide insight into the value of coordinated systems of care. We know that co-occurring disorders profoundly impact the individual, their family, and communities. And there's a tendency for SUDs and mental health illnesses to co-occur, and that can make their impact more extensive and complex to treat. So as knowledge of co-occurring disorders continues to evolve, new challenges have arisen. A principle among these is how we can best bring people into the care that is person-centered and tailored to their circumstances in life. This makes integrated models of care very important, as this allows providers to not only address behavioral health needs, but also those social determinants of health that impact outcomes. So these numbers that we see on our screens do not do justice to the individuals who must navigate complex health systems in order to receive treatment. I just want to acknowledge that these numbers all represent someone's child, someone's parent, someone's relative, and because of the severity of their conditions, they're often subject to stigma, social isolation, and unsupported care. Go ahead and go to the next slide, please. So complicating the presence of mental illnesses is the use of substances that have an impact on health and function. The use of substances such as opioids, marijuana, and alcohol among individuals not receiving formal treatment interventions is often to control the sequelae of mental health conditions such as racing thoughts, auditory hallucinations, thoughts of self-harm or depressed mood. Substance use may also temporarily ease symptoms only to have them return, sometimes more severely, setting up a cycle that further complicates treatment interventions. Go ahead and go to the next slide, please. Unfortunately, there's also a gap in the perception of need for treatment and the actual need for treatment. So we see on this slide that it's an estimated that almost 40 million people that are possibly in need of treatment do not feel that they're in need of that treatment. Go ahead and go to the next slide, please. Additionally, the statistics here highlight the impact of unintegrated systems of care on the appropriate screening and treatment of co-occurring disorders. Often conditions, either the mental health condition or the substance use disorder, are treated separately or in isolation. As we appreciate, co-occurring disorders are often reinforcing and should be treated in a comprehensive manner. With only 7% of people needing treatment for co-occurring disorders receiving both SUD and mental health care, we really can and we must do better. Go ahead and go to the next slide, please. We also know that difficulty in assessing treatment arises due to geographic disparity, stigma, a lack of resources or knowledge or practitioners in the health system unable to adequately identify and treat co-occurring disorders. All too often, we see individuals with co-occurring disorders receiving treatment for only a single condition. Go ahead and go to the next slide, please. Fragmented systems of care lead to complexity that hinders treatment and complicates recovery. primary prevention and harm reduction activities are not coordinated, while treatment is siloed across institutions. This makes navigating existing systems of care difficult and complicates access. This results in decreased access, stigma, increasing rates of overdose, and provider burnout and hesitancy. Go ahead and go to the next slide, please. So now we come to the HHS overdose prevention strategy. The focus on overdose prevention for SAMHSA aligns with the larger HHS overdose prevention strategy. Designed to increase access to the full range of care and services for individuals who use substances that cause overdose, the strategy prioritizes 4 key target areas: primary prevention, harm reduction, evidence-based treatment, and recovery support, and reflects the Biden-Harris administration principles of maximizing health equity for underserved populations, using best available data and evidence to inform policy and actions, integrating substance use disorder services into other types of healthcare and social services, and reducing stigma. SAMHSA really plays a key partnership in implementing this strategy, along with other operating divisions within HHS, including NIDA, CDC, FDA, and HRSA. We really try in this way with each agency through its unique work and focus to support the aims of the overdose prevention strategy. Go ahead and go to the next slide, please. Also in line with the HHS overdose prevention strategy is the principle of harm reduction. And I get really excited about this because last year is the first year that SAMHSA was able to award funds specifically for the work around harm reduction. So harm reduction emphasizes that evidence-based and promising harm reduction strategies reduce risks associated with drug use, including overdose and infectious disease transmission. Harm reduction also connects people to important health and recovery support services. Go ahead and go to the next slide, please. So SAMHSA's first ever harm reduction grant was awarded last year, $30 million through this dedicated harm reduction grant program. I'm proud to say that Cherokee Nation of Oklahoma was successful in their application for these dollars. The harm reduction grant program aims to help increase access to community harm reduction services. So I'd also like to share more examples of SAMHSA's commitment to supporting harm reduction. So we introduced the harm reduction grant, and funding for this grant came from the American Rescue Plan. Under the grant, harm reduction service providers are asked to develop or expand evidence-based services that may include but are not limited to the provision of sterile syringes, safe sex kits, prevention education about synthetic opioids and other substances, overdose prevention kits, including naloxone distribution, peer worker engagement, which I think is key, medical services, case management, and referral to treatment. Innovative harm reduction programs such as those funded under this new grant, we hope that first, they're going to keep people alive, particularly those in historically under-resourced communities, waiting to receive, long-awaited support to help stem the disproportionate number of overdose deaths and related health issues. Go ahead and go to the next slide, please. So as I shared, this supported funding promotes distribution of life-saving harm reduction interventions that include the naloxone kits, fentanyl test strips, and syringe exchange. These activities have been shown to reduce the incidence of overdose, limit exposure to fentanyl, and exposure to infectious disease. And beyond this, the harm reduction grants provide screening and targeted education that seeks to limit the health and psychological impacts of substance misuse. Go ahead and go to the next slide, please. Additionally, I'm excited to share a CDC SAMHSA partnership. So there's an investment of $3 million in the existing CDC's Harm Reduction Technical Assistance Center. The goal of this center is to improve the capacity and performance of harm reduction programs throughout the U.S. By ensuring access to high quality, comprehensive technical assistance. I encourage you to visit this website to learn more as what's available through this Technical Assistance Center for providers. Go ahead and go to the next slide, please. Also, in December of last year, SAMHSA co-hosted the National Harm Reduction Summit with the White House Office of National Drug Control Policy and the CDC. So this two-day meeting brought together partners and experts from local, tribal, state, and federal government and non-government organizations, including representatives from the fields of harm reduction, substance use prevention, treatment, recovery, and criminal justice. In addition, it underscored the value of lived experience by including people who used harm reduction services as well as those in recovery. A key goal of the summit was to develop a harm reduction framework to help guide policies, programs, and practices, some of which help SAMHSA guide these policies and programs and practices. Additionally, a steering committee was set up to follow up on the guidance received from this summit. Additionally, in August of 2022, our office hosted a virtual tribal harm reduction summit. We did this without a contractor or really any funds because we had heard from our tribal opioid response grantees and other people out in the field that this was something that people that were working in this field really wanted. We thought we might have 50, 100 folks. We had over 300 people register for this summit. It was amazing. It was really tribally led, and we had folks that were actually doing the work come and share, what they found to be effective, some really amazing programs, and also barriers that they're seeing. So we hope to follow up on that work this year, possibly with a second summit or working with our other technical assistants to set up a learning collaborative around that. Go ahead and go to the next slide, please. I wanted to share just briefly, in addition to the increased funding for the essential harm reduction activities, we've really sought to alter paradigms in care in response to the COVID-19 public health emergency. We had to pivot very quickly in a lot of ways that we were providing care. The flexibilities that were created during the COVID-19 public health emergency focused on rapid changes in the provision of treatment and reforms to complement harm reduction and prevention efforts. Unlike in most areas of medicine where practice evolves faster, opioid treatment program take-home standards have remained largely untouched until 2020. So in response to COVID, SAMHSA has been able to increase access to care through the expansion of telehealth for opioid treatment programs and take-home exemptions, improving uninterrupted care during the pandemic for those with OUD. Go ahead and go to the next slide, please. Additionally, in 2021, SAMHSA continued efforts to increase access to opioid use disorder services and treatment. Mobile units have played a key role, particularly in rural areas in that effort. SAMHSA issued guidance on utilizing block grant funds for mobile units, as well as provided guidance on how to establish mobile units and services. In November of last year, SAMHSA extended the methadone take-home flexibilities for 1 year, effective upon the eventual expiration of the COVID-19 public health emergency. We have also seen very positive impacts of these flexibilities, and SAMHSA is exploring ways to retain them after the public health emergency ends. Indeed, the flexibilities have been met with patient and provider support, since they are seen as patient-centered and safe models of care that also encourage providers to better tailor treatment to the individual. Beyond this, the flexibilities many patients to engage in important activities such as employment or childcare without having to visit an OTP program each day. This is particularly meaningful for those patients who live a long distance from OTP or have difficulties with stable transportation. Additionally, the 2023 Consolidated Appropriations Act is going to significantly expand access to medication for medications for opioid use disorder. The act, signed into law by President Biden on December 29th of last year, amended the Controlled Substances Act to eliminate the requirement for qualified practitioners to first obtain a special waiver to prescribe medications such as buprenorphine for the treatment of opioid use disorder. This ends a decade-long requirement originally put in place through the Drug Abuse Treatment Act of 2000. With this new law, the patient limits associated with this special waiver also no longer apply. Go ahead and go to the next slide, please. So we've been really looking at ways to expand treatment of opioid use disorder in our state. Opioid Response Grant, or SOAR, has played a major part in this. In this grant, funds go to states and territories. There's a lot of work that's being done around these grants to address opioid use disorder and reduce overdose deaths. We're really encouraging whole health, person's whole health be taken into consideration through integrated services and treatments. So some services that are provided include increasing access to treatment with the 3 FDA-approved medications for the treatment of OUD, reducing unmet treatment need and reducing opioid-related overdose death through prevention, harm reduction, treatment, recovery activities for OUD. SOAR funds have been used to expand access to underinsured, the criminal justice population, tribes, pregnant women, and young adults. Since 2019, close to 1 million people across the US have been served through the SOAR grant program. Go ahead and go to the next slide, please. So the companion to the state opioid response grant is the tribal opioid response grant. This program aims to address the opioid crisis in tribal communities by increasing access to culturally appropriate evidence-based treatment, including treatment for MOUD. Also, go ahead and go to the next slide, I think, and I'll share there. So since these funds were made available in 2018, you can see the amounts that have been awarded to tribal nations, tribal organizations. So just in last year, FY 2022, we awarded 102 grants for $55 million. Go ahead and go to the next slide, please. Wanted to share some of the successes and the thing that I find really exciting about these funds. So in 2016, SAMHSA, in partnership with tribal leaders and other federal agencies, established the National Tribal Behavioral Health Agenda. And within the National Tribal Behavioral Health Agenda is a cultural wisdom declaration, acknowledging cultural wisdom and honoring cultural appropriate practices. So with the Cultural Wisdom Declaration, we're actually able to fund cultural and traditional practices. So with these dollars, we've been able to fund sweat lodges, talking circles, traditional healers, gathering of Native Americans, teaching traditional cultural and practices, smudging, traditional dance, storytelling, teaching of herbs, drum ceremonies, social practices and prayer, medicine wheel activities, traditional craft making, healing fire, powwow camps, equine therapy, wilderness expeditions, and teaching farming, hunting, and fishing skills. And our grantees have shown some really good outcomes around incorporating these traditional cultural practices. Go ahead and go to the next slide, please. Also, certainly certified community behavioral health clinics play a huge part in our aim to integrate care. CCBHCs are required to meet certain standards, and in doing so, improve access to needed care and services. These services, which establish a basic level of services at which a CCBHC should operate, fall into 6 key program areas. staffing, availability and accessibility of services, care coordination, scope of services. So there's 9 required services, as well as person-centered, family-centered, and recovery-oriented care, quality and other reporting, and organizational authority and governance. In March 2022, SAMHSA released 2 grants to support CCBHCs, the CCBHC Planning, Development, and Implementation Grants, and the CCBHC Improvement and Advancement Grants. These grants are total 156 million, as seeking to support existing CBHCs and establish new CCBHCs in areas of need. Go ahead and go to the next slide, please. So you see here on this slide an example of a CCBHC required services. For too long, people have not had access to services they need, and even when they get services, they're often incomplete or fragmented. So an important way to ensure people are receiving comprehensive integrated behavioral health services is to offer them in one location. CCBHCs have become a central part of SAMHSA's strategy to increase access to comprehensive coordinated behavioral health services. The design is to solve that the problem of fragmented care by creating local entities able to connect anyone in need to this comprehensive package of integrated evidence-based mental health and substance use services. As this slide shows, CCBHCs provide a comprehensive range of the 9 required services, incorporating evidence-based practices and other supports based on a community needs assessment. Go ahead and go to the next slide, please. I wanted to talk a little bit about our SPARS data. This is our performance and accountability and reporting system. Our grantees report several indicators into the SPARS system, and it aggregates client level data across a range of our SAMHSA programs. Our internal data from the CCBHCs show encouraging evidence on the success of these programs. There's been an overall increase in positive health outcomes, an increase in daily functioning levels, a decrease in psychological distress, fewer hospitalizations for mental health care and ER visits for behavioral health issues, and a decrease for inpatient substance use disorder treatment, and a meaningful increase in social connectedness. These are encouraging findings, and they demonstrate the impact of CCBHCs. We really believe that they are transformative, accessible, and comprehensive. Go ahead and go to the next slide, please. I also wanted to share with you exciting development at SAMHSA with the creation of a new Office of Recovery. SAMHSA's recovery definition demonstrates recovery happens in communities and does not happen in a vacuum. There are many systems that are affected by individuals experiencing mental health and substance use disorders and their families, friends, loved ones, and allies. SAMHSA hopes to be able to further raise the profile of recovery from mental illness and substance use disorder by having one institutional entity that will lead this work in our agency. The Office of Recovery is going to coordinate with all of our centers and offices to ensure, as the national leader of recovery initiatives, SAMHSA has the capacity to bring together voices of our recovery communities to ensure that the million of Americans who have yet to find recovery can, and that the millions in recovery are able to sustain and strengthen their recovery. Go ahead and go to the next slide, please. It's also important to provide an update on current recovery-related activities. The agency-wide work group is one of our cross-cutting work groups that has a membership of over 60 staff from across SAMHSA. So we've been reviewing and updating our recovery materials, including our website, to ensure prominence of recovery at SAMHSA. There's a lot of programming around recovery, including our National Consumer Technical Assistance Center, our targeted capacity expansion, our state consumer networks, our Recovery Community Services Program, also B Corps, our Building Communities for Recovery program, and other discretionary grants for states, tribes, and community-based organization, creating innovative practices and programs to promote long-term recovery. We've tried to apply lessons learned to help build communities and professional capacity, to help create a movement of peer support specialists and recovery advocates, drawing attention to local, state, and national discriminatory policy barriers to sustain recovery, fostering the need for recovery research and education for public, families, and allies about the reality of recovery from substance use and mental and substance use disorders, and helping to support those that are impacted to live productive and happy lives. Go ahead and go to the next slide, please. We've also been working to promote equity, regardless of race, sex, sexual orientation, disability, socioeconomic status, geographic location, or other societal structures. All must have fair and just access, opportunity, and resources. The social and political determinants of health that negatively affect many communities and impact their ability to lead healthy lives. Despite relatively uniform rates of substance use among racial, ethnic, minority, and white individuals, racial and ethnic minorities are more likely to suffer social, legal, and health consequences from substance use. An example of this would be the war on drugs, the over demand for rejection, and along with discriminatory minimum sentencing for crack cocaine and disparate policing of communities of color has disproportionately impacted Black men with well-documented adverse effects on their health, employment, and social functioning. One of SAMHSA's efforts related to this is our co-sponsorship of the Healing Communities Study with NIDA, which is a cooperative grant to 4 research sites at the University of Kentucky, Boston Medical Center, Columbia University, and Ohio State University. The purpose of this study is to test the impact of an integrated set of evidence-based practices across healthcare, behavioral health, justice, and other community-based settings in reducing opioid-related fatalities. The evidence-based practices from this study will be used to inform SAMHSA technical assistance tools, which are used by our behavioral health workforce. Go ahead and go to the next slide, please. We're also looking at over a dozen programs at SAMHSA and our initiatives to increase access to behavioral health services, hoping to strengthen the workforce and diverse populations. And this slide represents specific populations that we are devoting our attention in this manner. Go ahead and go to the next slide, please. I also wanted to share specific programs and initiatives related to opioids. So we've talked a little bit about the Tribal Opioid Response Grant, and that grant runs out of my office. But we also have the Rural Opioid Technical Assistance. We have the National Hispanic and Latino Technology Transfer Center. We have a companion American Indian Alaska Native Technology Transfer Center. We also have centers of excellence for historically Black colleges and university, African American Behavioral Health Center of Excellence, LGBTQ+ Behavioral Health Equity Center of Excellence. We have the E4 Center of Excellence for behavioral health disparities in aging. We have the Asian American, Native Hawaiian, and Pacific Islanders Behavioral Health Center of Excellence that was just stood up last year. And then we also have the National Network to Eliminate Disparities in Behavioral Health. You can find all of the information about these programs on SAMHSA's website. Go ahead and go to the next slide, please. I also wanted to bring attention to SAMHSA's Center for Substance Abuse Treatment. This center works to expand access for realigning systems of care so that they are coordinated and integrated. And all of SAMHSA's grant programs related to substance use disorder originate from SAMHSA's Center for Substance Abuse Treatment. We're really advocating for coordinated systems of care as seen in common medical issues such as diabetes, resulting in increased access, higher rates of treatment, complex and meaningful care coordination, and lower morbidity and mortality. Go ahead and go to the next slide, please. We really believe that coordinated, integrated systems of care provides respectful and compassionate interventions, while it also fosters satisfying work environments that promote recovery, harm reduction, and primary interventions grounded in science. Go ahead and go to the next slide, please. Paradigms of care and research communities are struggling to keep up with changing patterns of use, illicit substances, and social pressures. Federal agencies are trying to rise to this challenge posed by the COVID-19 PHE with evidence-based policies that expand access to treatment and support recovery. We must work together to make treatment accessible to all, and policies that expand the use of telehealth or bring treatment to where the individual is, as opposed to them having to travel long distances to receive treatment, really reshaping how we deliver care to those who misuse substances. And we must do this through a compassionate, person-centered lens that promotes evidence-based practices and equitable care. Go ahead and go to the next slide, please. And I wanted to share this resource. I hope so much that you're already aware of it, but if you are not, I wanted you to be aware of this. So the Opioid Response Network is totally free to anyone. You do not have to be a SAMHSA grantee to access this resource. And I love it because the technical assistance is really designed to respond to local needs, provides free educational resources and training to the states, communities, and individuals. And I really love this because it does really tailor to the need, both small and large. When I was in Region 6, I was aware of a grandmother that reached out to the ORN, and unfortunately, she had lost her grandson to overdose. She saw other grandparents and parents in her neighborhood that were struggling as well. So she reached out to the ORN to find out how she could start a family support group in her neighborhood. At the same time, there was a large hospital in New Orleans that wanted to stand up medications for opioid use disorder to be able to induct folks at their ER and then get them connected to the peer network and ongoing services. It was a large undertaking. The ORN took that on and assisted that hospital. There's a lot of resources available in the ORN, and I would encourage you to go to their website and look at some of their materials, and also promote the ORN in your scope to be able to come alongside and assist folks. Go ahead and go to the next slide, please. There is SAMHSA's number and SAMHSA's contact information. I also put my direct contact information in the chat. And if we want to stop sharing, I'd like to have some time to answer any questions or provide any kind of additional information that that you might have a desire to know.
I don't really know what to ask, except that I was just unaware that SAMHSA did as much as they do. I mean, I guess I knew in a way, but not specifically, people that actually handle the funds and the programs. And, I use them as a resource when I'm doing research just to find out what's being done, but to actually have access to somebody who really has their hands in it. It's just very different, SAMHSA is just kind of this big nebulous thing that we know about, just kind of.
But something that's really interesting to know is, so of course, we are supported by a cadre of folks that, contract and support us. But SAMHSA is a relatively small agency. I think at last count, full-time FTEs, I think we were only about 678 folks. So yeah, so compared to an organization, HRSA, right, that has thousands, but through our contractors and their grant funded entities and our cooperative agreements, we're able to produce this huge amount. And you're right. If you visit our website, you'll see tips for practice. You'll see our COVID website is really good as well. It shows all of the flexibilities that are available right now related to COVID, and just there's a lot of amazing material. Sometimes it overwhelms us too on the website.
I mean, I use it for every program. I mean, because I'm a social worker, so whenever I'm doing anything on substance abuse or health related issues or anything on the disparities in health, or that's who you go to. I mean, you're going to get some information from them and Centers for Disease Control. There's a few folks you go to, but to actually hear something more specific about them, other than this website that just has all this information, makes it more
Absolutely.
real.
Absolutely.
Ms. Lowe, you have your hand up.
Yes, I have a question. So I think I wanted to know, are there any departments within SAMHSA that helps with being able to process those different grants and those applications? Because I know that there's probably people who would like to partner, even if it's, small agencies that are probably already doing the work, but are not familiar with the processes and the applications, and just seems overwhelmed. So are there any people within the SAMHSA community or departments that help with those applications to get those funding?
So I just want to acknowledge that the system that we have for application and for management of grants can be quite complicated. And
Yes.
that's exactly what you're saying. And
Yes.
working in the Office of Tribal Affairs and Policy, so our job is to do consultation and connect with tribal leaders, tribal, providers, and we hear that a lot. And I think that tribes are no different really than other kind of rural organizations or smaller organizations that might have little infrastructure to be able to apply and manage for grants. So we do time through our technical assistance centers have webinars and have other kinds of education to help folks. A lot of times when we put out a new notice of funding opportunity, we'll have a pre-application webinar where people will be able to ask questions about the NOFO and be able, to gain understanding. If you go to SAMHSA's grant page, there's also tools on that page. So because, there's certain steps that folks need to do prior to application that they may not be able to get accomplished, if they see the grant, they may have 6 weeks, 8 weeks to apply, and there may not be time to do those preparation things that you need to do to be able to apply. So I would encourage folks to go to our website and take a look at that as well. We are also advocating though for and looking at ways that we can reduce the burden of this, because we acknowledge that that is an issue and a potential barrier for the people that need these funds the most to be able to access them.
Okay. All right. Thank you.
Any other questions or comments from the group? I don't see any right now. I just want to thank you again so much, Captain Herod. This was very informational, and I just hope some of the folks on the line today can take advantage of these opportunities and, really use them to build the behavioral health and substance use infrastructure.
Oh, I appreciate it. I just want to share too. So SAMHSA is allowing me to serve from Oklahoma. So I'm actually coming to you from McAllister. So my office is in Rockville, Maryland. But we have at SAMHSA, most of our positions now are 100% remote if you request that. I'm so glad that we've made the decision to do that, because I think it's really going to contribute to the folks that are able to come from varying backgrounds and be able to contribute. So, so I'm here in Oklahoma. I've shared my contact information. So if anyone ever has a need, you can't find what you need, or you need a connection, please reach out to me, and I am so happy to make that connection for you.
Oh, that's wonderful. Thank you very much. Thank you very much. All right. Well, if we don't have any other questions or comments, we can adjourn for the afternoon. And I just thank you again for your presentation today. It was lovely to see you again. And I just hope everyone has a wonderful weekend.
Thank you. It was an honor to be able to spend time with you today. It's so good to see you again as well.
Great.
I hope we see each other in the future.
Yeah, same here. Same here. All right. Thank you all.
Thank you.